Hi, everyone. Welcome to Grand Rounds. I apologize for the background noise. I'm just at work right now on a shift. So once I get things started, I'll be handing things over to our lead residents, and thanks very much to them for helping today. Our first speaker today is Dr. Tom Winter. He's an emergency physician at HSC, and he'll be speaking today about the modified brain injury guidelines. Tom, thanks so much for speaking, and I'll turn things over to you.
Great. Thanks for the introduction. Yes, so I'm going to be talking about the modified brain injury guidelines today, and we'll just jump right in. And we're going to start with a case. So, case one is of a 35-year-old male who is at work. He was previously healthy. He's on no medications. He unfortunately trips and falls down the stairs, and he hits his head. He has an isolated head injury. His GCS is 15, and he's got no neurological deficits. CT head shows a small subdural hemorrhage. Case two is the same exact case. The 35-year-old previously healthy male who falls down the stairs has an isolated head injury, is neurologically intact, but this time he has a small epidural hematoma. Excuse me. Case three is the same patient who falls down the stairs, has an isolated head injury. His GCS is 15. His CT shows a trace 1 millimeter subarachnoid hemorrhage into sulci this time. But this time he states he had 2 cans of beer at work because he was so frustrated that his computers and dictation software wasn't working. So let's stay on this version of the case. A patient with GCS 15 who's neurologically intact, who has a 1 millimeter subarachnoid hemorrhage into sulci. His alcohol level comes back very low at 5 millimoles per liter. You reflexively pick up the phone and call neurosurgery, and you get yelled at over the phone for how trivial the bleed is and how trivial the consult is, in their minds at least. Which gets to the crux of the issue today. What do you do with mild traumatic brain injuries and small intracranial hemorrhages? Are there guidelines that can help us make decisions in these cases? And so the conclusion of this talk, if you're going to tune out from here on out, is that the modified brain injury guidelines are a validated tool that help us safely risk stratify mild TBI patients with intracranial hemorrhage. They help improve resource utilization by decreasing the need for repeat imaging, neurosurgical consultation, and hospital admission. Overall, the tool, as you will see, is very sensitive, helping us rule out which patients need neurosurgical intervention. So the objectives for today are one, to go over some relevant background information on mild TBIs and bleeds. Two, to review the brain injury guidelines, which are the original guidelines. Three, to transition to the modified brain injury guidelines, which came out in the last 5 or 6 years. Four, to discuss some of the limitations of the data. And then finally, to talk about how we apply this set of guidelines to our patient population and future directions of the data and research. So in terms of background information, there's about 137,000 TBI ED-related visits each year. 21,000 of those result in hospitalization in Canada. This results in massive costs, probably in the range of $1 billion just for hospitalization alone. But the costs are even more once you include direct and indirect costs. So somewhere between $8 and $10 billion annually when you include missed work. And we now know that CT technology in the last couple of decades has improved substantially. So we are detecting more and smaller bleeds than ever. Yet we know from the literature that in general, less than 10% of patients with these small bleeds and mild TBIs actually end up needing neurosurgical intervention. So, whereas traditional management would include a repeat head CT, routine neurosurgical consultation, and hospital admission or prolonged stay, I'm going to get into some data that suggests we don't need to be doing all of these things. In addition to this traditional management here on the slide, patients are often transferred from community hospitals or rural centers to more capable trauma centers for evaluation as well. So enter the brain injury guidelines. Because we lacked clear definitive guidelines for non-op management of mild TBI, a group of American authors created the brain injury guidelines in 2014 by Joseph et al. They started by doing a retrospective review of 3,800 blunt TBI patients that presented to a level 1 trauma center. And they categorized patients based on neurological exam, history, and CT findings. They then used these three features to generate recommendations on whether hospitalization, repeat head CT, and/or neurosurgical consultation were required. And they had a number of definitions of relevant or important things as well that they laid out in this first paper. So they defined progression of bleed on repeat head CT as an increase in the number of areas of bleeding in the brain or size of bleed seen. They defined an abnormal neurological exam as a focal neurological deficit, an abnormal pupillary exam, or a GCS score of 12 or less. And they define neurosurgical intervention as craniotomy, craniectomy, and/or EVD or ICP monitor placement. Patients were classified into Big 1, Big 2, and Big 3 categories, 3 representing the most severe. And patients had to meet every single criteria in each category or they were upgraded to the next category. So in Big 1, patients had a normal neurological examination. They were not intoxicated. They were not on warfarin, Plavix, or aspirin. And they had minimal findings on head CT, meaning no skull fracture, bleeds that were 4 millimeters or less when considering subdural hemorrhages, epidural hemorrhages, intraparenchymal hemorrhages. They had quote unquote trace subarachnoid hemorrhage, which is vague, which I'll get back to later on. And they had no intraventricular hemorrhage. And for this group of patients, they said management should include no hospitalization, but observation in the ED for 6 hours, no repeat head CT, and no neurosurgical consultation. Big 2, in the moderate brain injury group, the neurological exam was normal. The patient was on no antiplatelets or warfarin. You could have a non-displaced skull fracture, and bleeds were a little bit larger at around 7 millimeters or less. For this group of patients, they proposed hospitalization, no repeat head CT, and no neurosurgical consultation. And then finally, in the Big 3 category, these are patients with severe bleeds or injuries. They proposed hospitalization, repeat head CT as needed, and neurosurgical consult. And importantly, in this study, none of the patients assigned to Big 1 and 2 categories required neurosurgical intervention versus 13% of the patients assigned to Big 3 category required neurosurgical intervention. This study was followed up by another trial by the same group of authors, but this time it was a prospective observational trial published in the same year in 2014. The main question of this study was to evaluate the safety of managing Big 1 category patients without neurosurgical consultation and instead by trauma or acute care surgeons. So, patients meeting Big 1 criteria were managed without neurosurgical consult and then were matched to a similar cohort of patients managed with neurosurgical consult before implementation of the rule. The primary outcome was need for neurosurgical intervention. In terms of results, there were no differences in baseline characteristics between the group. 0% of the Big 1 group required neurosurgical intervention overall. In the acute care surgeon group, or i.e. the no neurosurgery consult group, they found that these patients were less likely to get repeat head CTs, less likely to get admitted to hospital, and on average had about $4,500 in cost savings per visit. So the authors concluded that patients cared for by trauma surgeons had a shorter hospital stay and also overall lower hospital costs than when compared for by neurosurgeons. The same group of authors then completed a larger prospective observational multi-institutional trial at 9 trauma centers published in 2022. They looked at around 2,000 patients. Inclusion criteria, which were similar to the prior studies, were patients aged 16 years or older with TBI and a positive head CT, meaning there is a bleed or skull fracture. Patients were excluded if they had a penetrating brain injury or they were transferred from other hospitals. Primary outcome, again, as per prior studies, was need for neurosurgical intervention. And there were some secondary outcomes as well, such as neurological exam worsening, progression of bleed on repeat head CT, post-discharge repeat ED visits, and 30-day readmission. In the big one group, none required neurosurgical intervention. Only 1.3% had progression of hemorrhage on a repeat head CT, and none had clinical deterioration. So you're starting to see a pattern here, especially in big one, that these patients basically never require neurosurgical intervention. In the big two category, none required neurosurgical intervention. 7.1% had progression of bleed, and 0.7% had clinical deterioration. And in the big three category, 13.8% required neurosurgical intervention, and a lot more had progression of bleed and clinical deterioration as expected. There were some readmissions within 30 days that only happened in the big three category. Some of the big one and big two patients did represent to the hospital, but the authors note that none of them represented related to their TBI. Often these patients had other injuries as well. The authors found that big implementation would have resulted in 425 less repeat head CT scans, 401 less prolonged hospitalizations, and 511 less neurosurgical consultations. In 2022, a systematic review and meta-analysis on all relevant big literature came out. 13 articles were included, the majority of which were retrospective. A total of 9,000 TBI patients were included. The group was comprised of about 1,400 big one patients, 2,100 big two patients, and 3,100 big three patients. Here's a sensitivity plot that basically shows that overall, the pooled sensitivity for predicting neurosurgical intervention was 1. The pooled sensitivity for predicting radiological deterioration was 0.98, but the rule is overall poorly specific. So overall, the conclusion, looking at the body of big data, is that big criteria are highly sensitive and are good at ruling out patients that will need neurosurgical intervention, but the criteria as a whole are not good at predicting which patients will require surgery in the other big categories, i.e., they're poorly specific. So we're now going to transition to our third objective, the modified brain injury guidelines. So despite how good some of the data that I showed has looked so far, there are some limitations and issues with the brain injury guidelines. This group of authors in 2020, Khan et al., published a retrospective cohort study at 3 trauma centers and found that using big one and big two criteria, about 11% in each group had progression of bleed on repeat head CT. 0 in the big one category required neurosurgical intervention, but 2 in the big two category required neurosurgical intervention. So these numbers were higher than what were previously seen. And those 2 patients in the big two category that required surgery were patients that had epidural hemorrhages. So they reviewed all the data and they said there are some limitations with big. The first is that epidural hematomas are known to be high risk, so should be categorized differently. The second is there is some issues with reproducibility in terms of lack of clear definitions and criteria and lack of clear disposition rules and planning in the original big guidelines. And then finally, DOACs were emerging and were not included in the rule. So this needed to be addressed as well. So whereas in the initial big study, GCS was in the chart written as quote unquote normal, in mBIG it is defined as 13 to 15. Intoxication in the original big guidelines was not defined. In mBIG, it's defined as a blood alcohol content of 80 milligrams per deciliter, which is 17.4 millimoles per liter, or around the legal driving limit in most provinces. ASA, warfarin, and clopidogrel in the original guidelines were automatically put you in the severe category or big three. In mBIG, you could be on any dose of ASA and it was totally excluded. So it was not thought to be a risk factor for progression of bleed. But if you're on any other DOAC or any other antiplatelet, you're automatically put in the severe mBIG 3 category. Big defined subarachnoid hemorrhage as trace or scattered, which was very vague and was hard for radiologists to reproduce. In mBIG, subarachnoid hemorrhage and bleeds are defined in terms of millimeters, hemispheres, and sulci. And then in big, epidural hemorrhages could be big one, but we know looking at the literature that these hemorrhages are much higher risk. So the mBIG authors ended up putting all epidural hemorrhages into the severe mBIG 3 category. And finally, disposition was a lot clearer in mBIG, which I will get to in a second. So here's a familiar table that you have seen before. And this just shows the neurological exam history and CT findings per each of the mBIG categories. I won't go through this because we've basically reviewed the high yield stuff on the previous slide. So for the mBIG 1 group, they recommended, the authors recommended no hospitalization, 6 hours of ED observation, no repeat head CT, and no neurosurgical consult. This was similar to the big guidelines. In mBIG category 2, they recommended hospitalization specifically for 24 to 48 hours, no repeat head CT, and no neurosurgical consult. And then this is all new here as well. For both groups, the authors wrote that every patient should have a neurocheck Q2H, should have a trauma team reassessment at hour 3, and should have an attending reassessment at hour 6. And also note that all discharged patients must be GCS 15 or at baseline. So all of that stuff was missing in the original big guidelines. mBIG 3 patients all get hospitalized because these are patients with severe bleeds. They all get a neurosurgical consult, plus or minus repeat head CT, depending on the case. In 2022, the first derivation of mBIG criteria was followed up by another study by the same group of authors, Khan et al., who published a retrospective observational analysis of prospectively collected data over 2 study periods. And they compared performance of mBIG versus prior standard of care. They found that mBIG decreased hospital admissions, repeat head CT scans, and neurosurgical consultations, and all these results were statistically significant. They did find that 8 patients in their study cohort of mBIG 1 and 2 patients did clinically worsen, which is defined as a GCS of 12 or less, development of a focal neural deficit, or a pupillary abnormality. In the mBIG 1 category, 2 patients clinically got worse, but none, importantly, needed neurosurgical intervention. In the mBIG 2 category, 6 patients clinically got worse, and 1 ended up requiring neurosurgical intervention. But very importantly, the clinical worsening was during the recommended observation period set out by the authors, highlighting that in the rare case that a patient actually deteriorates using these guidelines, the recommended observation period is sufficient. There have been many other studies that have looked at mBIG. This study found that implementation of mBIG guidelines could have decreased the need for transfer from another urban facility to a trauma center, suggesting that 35% or more transfers could have been avoided when looking at mBIG 1 and mBIG 2 patients. Another retrospective study, this time in a community hospital, showed that implementation of mBIG protocol would have saved about $250,000 during the study period in a group of 116 patients. Overall, in terms of reviewing the big and mBIG literature, there's about 30 published studies so far. There are some limitations to the data, though. The first is that we're working with mostly retrospective data, although there have been some prospective trials. There hasn't been a trial that's solely focused on a geriatric population, but there have been some studies that do somewhat capture the geriatric population as well. Uh, some of the studies lack rigorous longitudinal outcomes, although, as I alluded to before, there have been a few that have looked at presentations and readmissions. And then the disposition bit is a little bit tricky. So by the book, mBIG suggests a fairly rigorous like reassessment protocol, something that we're probably not doing in its current form for our trauma patients. So they recommend NeuroCheck's Q2H, a trauma team reassessment at hour 3, and then an attending assessment at hour 6. We're going to now transition to our last objective, which is how do we apply these set of guidelines to our patient population, and what is the future of research here, and what does the data show? So there are now multiple centers across North America that are using mBIG guidelines. In Vancouver, at Vancouver General Hospital, where I previously worked, we implemented these guidelines a few years ago. Where Holly works in Victoria, they're also using mBIG as well. And I reached out to a number of other centers across Canada, Toronto, Ottawa, Calgary, Edmonton. And although they haven't formally implemented mBIG yet, certainly they are considering doing it. And to further illustrate what this would look like at Vancouver General Hospital, I'll just go back to case 3 at the beginning. So here's our 35-year-old who fell down the stairs. He's got an isolated head injury. Remember, he had 2 king cans. His alcohol level is 17 or less than 17.4 millimoles per liter. His GCS is 15. The CT shows a trace 1 millimeter subarachnoid hemorrhage in 2 sulci. Radiology at Vancouver General Hospital would generate a report like this. So they'd say impression, the left frontal lobe has 2 small areas of subarachnoid hemorrhage without surrounding mass effect. mBIG criteria, skull fracture, no. Subdural hemorrhage, no. Epidural hemorrhage, no. Intraparenchymal hemorrhage, no. Subarachnoid hemorrhage, less than or equal to 3 sulci involved and less than or equal to 1 millimeter thickness. And intraventricular hemorrhage, no. The emergency physician would then use the other clinical mBIG criteria and dispo the patient based on whether they were mBIG 1, 2, or 3. So in this case, the patient meets all the clinical and radiographic criteria to be mBIG 1. So his disposition is 6 hours of ED observation, but no hospitalization, no repeat head CT, and no neurosurgical consultation. And during the observation period, you'll recall the patient gets NeuroCheck's Q2H, a trauma team reassessment at hour 3, an attending assessment at hour 6, and the patient must be GCS 15 or at baseline GCS when discharged. In terms of our local perspective, I spoke to our neurosurgeons and radiologists. There seems to be a lot of interest locally. However, mBIG hasn't really been on our radar up until this point in time. Radiology thinks it would be very easy to modify the reports they currently generate to include mBIG criteria. Neurosurgery thinks there's a lot of promise here, particularly focused on the safety of the mBIG 1 category. Overall, it would take all of the relevant services to get on board to implement this. In terms of future directions, there's currently a group in Quebec that is running what's called the Quebec trial, which stands for Quebec Brain Injury Category Study. They are developing a similar set of guidelines to mBIG, and there are Canadian centers participating in this trial as well. Because some Canadian centers are participating in this trial, like Ottawa, it obviously would preclude them from adopting other guidelines like mBIG during the study period. And there should be a number of mBIG publications this year, including possibly another meta-analysis and systematic review that's coming out in the near future. So in conclusion, the modified brain injury guidelines are a validated tool that help us safely risk stratify mild TBI patients with ICH. They help improve resource utilization by decreasing the need for repeat imaging, neurosurgical consultation, and hospital admission. Overall, the tool is very sensitive, particularly the mBIG1 category, and help us rule out patients that need neurosurgical intervention. In other words, mBIG reliably identifies which patients won't get worse, and that is where the value of this rule lies. Thanks for listening to my presentation. I'll now take any questions.
Thanks, Tom. I'll start us off. I was just wondering, in terms of the epidural hematomas, do you know if there's any subcategorization? Like, would a temporal pole, temporal epidural hematoma be treated differently than other epidurals because they're usually venous? Are they all universally considered mBIG3, or are there any exceptions?
That's a great question. The authors do not dive into that level of detail in their paper, but everyone with an epidural just gets put into the mBIG3 category.
Tom, I have a question. That was excellent, by the way, and very informative. Thank you. When you spoke to neurosurgery and radiology, I'm just wondering what was the limitations in implementing this when the literature is very clear, especially for mBIG1, like you said. What has to happen from their perspective for this to be bought in or for everybody to be on board?
Honestly, not much. I talked to Dr. Ying from radiology, and he said it would be super easy to do. I messaged like McCarthy a few times from the trauma team, and I just didn't hear back from trauma,
Yeah.
despite a few inquiries. So we would need to get the trauma team on board. And then neurosurgery. I talked to Jordan Arbor's wife in neurosurgery, and she thinks there's a lot of promise in this. And again, she just thinks that we would need to get everyone on board, the rest of the neurosurgical department on board as well. She did say there were a couple of her colleagues that like to follow subdural hemorrhages because there's a couple of weird things that can happen with subdurals, so they will follow them several months out. But per mBIG criteria, if you're mBIG1, for example, you wouldn't even be talking to a neurosurgeon, meaning the neurosurgeon wouldn't even find out about these subdurals in the first place. So I think everyone seems like fairly interested, and
Mhm.
I don't think there would be a lot of barriers given like there's a decent amount of evidence at this point.
Awesome. Thank you.
Julian had a question.
Yeah, and less of a question and more of just a statement. I do wonder whether or not if there's going to be a barrier to wide implementation, it's going to come from the trauma service, because I expect that those folks that are not going to require neurosurgical intervention, but will require a period of hospitalization and monitoring, are not going to routinely be welcomed with open arms onto the neurosurgical floor, and rather than are going to be admitted to gold. And I do wonder whether or not that might be a barrier that we will need to that we would need to engineer out of a policy.
Agree. I think that's a great point. So in mBIG1 category, I mean, a 6 hour observation period is easy. We can easily do that in the emergency department. But as per mBIG2, which I think is what you're referring to, they recommend a 24 to 48 hour observation period. We often also do that in our emergency department, but that is also not ideal. So finding the correct service to admit if we are enacting these guidelines would be a challenge.
Right. So if there's no other burning questions, thanks again, Tom. Great talk. And we'll welcome our next guest to set up their slides. So our next presenter is Richard No, one of our third-year CCFP-EMs, and he's going to be presenting today on POCUS in cardiac arrest, Pseudo-PEA, resuscitation futility, and evidence-based resuscitation decisions.
Okay, can everyone see my slides?
Uh, Not yet. There you go. If you can put that into full screen.
All right, we'll get started now. So I'm going to talk on POCUS in cardiac arrest, essentially 2026 evidence updates, and we'll get right into it. So full disclosure, I did use AI to make the title of this talk, and even back in 2021, there was a paper that looked into AI to creating research titles. I like to think that my titles have been getting better and better since AI has been moving. Disclosure, I'm a resident physician with no relevant financial relationships or conflict of interest disclosed. And I just want to give a special thanks to Dr. Tom Jellick for his guidance in the creation of this talk. So the objectives that we'll be talking about here is we're going to look into identifying reversible causes that can be seen on POCUS. We're going to look at what POCUS can be used for prognostics of the resuscitation, specifically distinguishing pseudo-PEA from true PEA, and then comparing POCUS versus manual pulse checks, recognizing the harms involving use of POCUS, specifically time off the chest compressions, and then this concept of using TEE and bespoke CPR, which I will get into further into this talk. So in terms of the scope of this talk, we're going to focus specifically on adult medical cardiac arrest, as the trauma cardiac arrest has its whole different algorithm, and essentially, for the most part, they use POCUS to identify if cardiac standstill is present or not and determine it. But medical cardiac arrest, specifically in the realm of the non-shockable rhythm, has POCUS's main utility is found in that. So a bit about the AHA 2025 guidelines. In terms of the differences from the 2020 guidelines versus 2025, POCUS is still labeled as a core 2B evidence-based, where they do have recommendations in terms of the evidence that it's the same classification. However, a couple of subtle changes have been made where they essentially say that those who are experiencing POCUS...
Richard, sorry to interrupt you. If you could just move that window, the bottom right. I think that's your screen.
Oh, yeah.
Thanks.
Yeah, sorry about that. So essentially what this says that for those who are experienced with POCUS, they can ultimately use it to identify reversible causes. And in terms of the evidence of the body of literature in regards to POCUS itself, most of this is primarily, these studies are primarily in the cohort studies and case series reports, mainly because of the fact that it's ethically impossible, if not difficult, to do POCUS studies within the randomized control trials, mainly because of the ethics involved. So that's just in regards to the evidence involved. Just further break down the details of the guidelines. Essentially, they recommend now in the 2025 guidelines, POCUS be used to identify if the endotracheal tube intubation has been confirmed, and if pseudo-PEA or PEA is present through examination of the heart, and then identifying if there's reversible causes are seen. So going into our first objective here, using POCUS to identify reversible causes in medical cardiac arrest. So going through our H's and T's here, POCUS can only be used for certain H's and T's involved here. And with these involved, essentially you can look at hypovolemic, if the patient's in that state, if there's a tensional pneumothorax that's present that's causing the arrest, if there's a tamponade, or if there's a thrombus, specifically pulmonary embolism, that is causing the arrest as well. So these are the main causes, H's and T's, that can be examined using POCUS. I won't go into this too much detail because most people here generally know what the signs involved of these H's and T reversible causes that we've seen with POCUS. But first I want to get into is a case here. So we have a 62-year-old man who was found pulseless, apneic. He was found in a casino. Security guards applied the AED on him, found asystole on monitor. They started CPR and epi infusions or epi doses. And subsequently, when he was brought to the ED, they found he was still persistent asystole. A POCUS probe was placed on subxiphoid during the rhythm check. And they identified this on the ultrasound itself. And ultimately, what the ultrasound here shows that there's doesn't seem to show any organized contraction, but rather this fine, disorganized ventricular activity, which is deemed as occult ventricular fibrillation in the literature. So as you can see here, it's quivering of the myocardium itself and the ventricles themselves aren't contracting essentially. So what this occult ventricular fibrillation is that if you see a non-shockable rhythm on the monitor, whether it's asystole or PEA, and if you see this ultrasound findings of the quivering, this is essentially what is deemed as occult ventricular fibrillation. And in a recent paper in 2025, that a multi-center prospective observational study looking at 811 out of hospital cardiac arrest, they want to identify what portions of patients who have ventricular fibrillation that's visible on the POCUS compared to those who have a non-shockable rhythm on the ECG is present. And through the results, they found that those of 811 patients, occult ventricular fibrillation was present in 5.3% of the time, whereas ECG ventricular fibrillation was found 24.9% of the time. And with those who present with occult ventricular fibrillation, they presented with either PEA or asystole, mostly predominantly PEA. And it turns out that occult ventricular fibrillation was less likely to be defibrillated compared to ECG VF. However, when it was defibrillated, however, the resuscitation achievement of ROSC was quite similar in terms of rates, whether it was ECG seen for ventricular fibrillation or through the ultrasound. So they ultimately concluded that ROSC was similar in both ECG VF and occult VF, and identifying occult VF may ultimately change management in regards to this. So the key takeaway from this study is that while occult VF is uncommon, it is clinically important because essentially it changes outcomes when we ultimately deal with it being present and identified during the resuscitation. So going back to our original case here, occult ventricular fibrillation was seen on the echocardiogram, therefore a shockable rhythm, and as a result, the patient was defibrillated. The rhythm then became on the ECG ventricular fibrillation, and therefore a second defibrillation was given, and then ROSC was achieved. So as a result, when we go back to the reversible causes that can be identified with POCUS. Going into our second objective here, POCUS for prognosis. So what counts as cardiac activity to begin with? As you can see here, these are all different views of what you can see during arrest. When we have these organized coordinated contractions on the ultrasound itself, but there isn't a pulse, this is known as Pseudo-PEA. And when we have that quivering of motion, this is usually motion, absence of any motion. This is called cardiac standstill. And with cardiac standstill itself, 2001 was a major study of standstill, and they found that essentially all patients without any cardiac activity had no survival out of the 136. So their takeaway was that there was that cardiac standstill was essentially indicated no survivability. New studies that have come since 2001 have also looked into this, and they did find that while there's some survivability compared to the original study, it was minuscule at the most, where the Reason trial, for example, which we'll be talking about, found that was 0.6% when there was cardiac standstill in the end, and if survivability occurred or not. So I think the main takeaway from this is that cardiac standstill is something that can be used to identify the prognosis involved with resuscitation as a strong predictor of survivability. Ultimately, though, using it with other tools in determination of resuscitation, such as downtime, number of epinephrine use, should be used at the end of the day. And this is something I see in practice a lot in the merge. Going into a second case here, this is a 62-year-old man who has a witness collapsed. There was a downtime of 8 minutes. 2 EPIs were given here. And on the monitor itself in the merge department, they see this narrow, complex, organized rhythm at 80 beats per minute. There was no palpable pulses noted. And essentially, they diagnose this as PEA here. In terms of PEA versus asystole, PEA is essentially when we can identify there's no pulse present, but there's still electrical activity present within the heart, so we could observe that on ECG. However, if left untreated, this can develop into asystole, where there's no electrical activity and no pulse present. And in regards to the ACLS algorithm itself, I find that although they ultimately identify in the non-shockable rhythm that asystole and PEA are both of the same features that require the same management, but in terms of the electrical mechanical pathophysiology itself, they both are very different at the end of the day. And ACLS ultimately is quite rigid in the fact that they are suggestive that the management be the same despite having these variation in pathophysiology, which will help explain what the next concept that I'll allude to. So ACLS basically essentially wants you to treat these as both the same things. So that kind of alludes to the next concept of the pseudo-PEA, where there's no palpable pulse present. There's a non-shockable rhythm noted on the ECG. And then when you put the probe on with the ultrasound, there is organized contractions noted, which would be deemed as pseudo-PEA. And when there's no organized contractions, this would be deemed as PEA. So pseudo-PEA essentially is when you see with the ultrasound probe, there's contraction involved. And this brings us to the idea of that PEA itself is on the continuum in terms of pathophysiology. So we have our normal circulation here where a pulse is present, which can turn into peri-arrest shock, where a pulse is still present, but the blood pressure is arbitrary less than 60. This then dwells into pseudo-PEA, where there's no pulse present at this point, but there's still mechanical activity noted on the ultrasound itself when we look at the heart, and there's still electrical activity noted on the ECG monitor. And then this can dwell into PEA, where there's no pulse present, and now there's no mechanical activity appreciated on the ultrasound, but there's still electrical activity present. And then finally, asystole, when there's neither pulse, mechanical, or electrical activity that is present. And ultimately, the reason why we care about the spectrum is that it changes the management itself. As PEA, we go through the ACLS algorithm with CPR and epinephrine, but pseudo-PEA, we end up treating it as a profound hypotensive state where the patient is given pressors, boluses of fluids, and essentially no CPR involved. Just a bit of a side here, epinephrine itself isn't a benign medication as it can cause harm if potentially given pseudo-PEA. The famous Paramedic 2 trial looks into this and essentially found that while it does achieve higher rates of ROSC with epinephrine compared to saline doses, the patients end up having higher neurological poor outcomes in the end, which is out of scope of this talk. In terms of the landmark papers involved in examining pseudo-PEA, the REASON trial is one of the biggest trials that have looked at this past. This is a prospective multicenter observational study involving 793 adults looking at non-shockable cardiac arrest rhythms, whether it's PEA or asystole in US and Canadian emergency departments. They were essentially asking, is detection of cardiac activity on POCUS in patients with these non-shockable rhythm is associated with improved survivability from cardiac arrest? It was the largest study at its time, essentially. And essentially the results were that they found that ROSC was achieved in over 50% of those with cardiac activity noticed on POCUS. And the survival to discharge was 3.8% with cardiac activity itself. And then 54% of those PEA patients had cardiac activity on echo. And this also reinforces the idea that manual palpation itself is an unreliable adjunct to during the resuscitation, and then that cardiac standstill itself wasn't an absolute predictor of death compared to previous studies, but still the survival of discharge was very low at 0.6%. Key takeaway from this study is that bedside ultrasound in non-shockable rhythms can essentially identify pathophysiologies such as pseudo-PEA that require specific interventions and should be used as an adjunct to discontinue resuscitation efforts as well, if necessary. So going back to our case 2 here, in terms of the POCUS finding, we identified that there is a mechanical contraction of the heart on ultrasound, and as a result, this was deemed pseudo-PEA rather than true PEA. The management was then changed to providing rapid fluids, push dose vasopressors. CPR was discontinued. After 2 minutes, a carotid pulse was palpable on manual palpation, and ROSC was successfully achieved. So therefore, POCUS plays a role in the changing of the management in this case. In terms of POCUS checks, pulse checks is better than using the manual palpation. So a large systematic review in 2026, January, very recent, looked into this, the studies involved with this, and they ultimately found that they ultimately tried to identify if the POCUS probe was quicker and more accurate than manual checks themselves. And their key takeaway was that ultimately POCUS was faster and more accurate, despite regardless of the type of method that we use, B mode or Doppler mode or compression visualization. A Canadian study looking into this had a workshop where physicians, healthcare providers attempt to identify the carotid pulse in live patients using ultrasound versus palpation, and they also found that there was higher first rate attempts, success attempts with ultrasound, and less variability as well. In terms of the different methods involved with identifying pulse on POCUS, Doppler mode is one of the methods that can be used, and this essentially sees the flow through it, and then there is B mode involved as well. There has been studies, in terms of practicality itself, B mode, as suggested by Dr. Jellick, is more practical because essentially Doppler is more complex involved and you have to push more buttons, and during a resuscitation, this is not ideal. Placing the probe on, pushing on the artery to see if there's pulsation is essentially quicker intuitively itself. One study looked into this specifically, the difference in timing in regards to this, and they found that the pulse using B mode led to 3.7 seconds to 4.8 seconds, compared to Doppler, that's 7.6 seconds to 9.6 seconds, and compared to manual palpation, 9.3 to 10.8 seconds. So both modalities were superior compared to manual palpation in the end. And other tools to help suggest, identify whether pseudo-PEA is present is that we can also look at diastolic blood pressure with an art line placed during resuscitation as well. And essentially with this art line here, the POCUS ultrasound to identify if there's pulsation present and to see if there's mechanical organized activity present. These are tools that essentially can help identify if pseudo-PEA is present or not. So we talked a lot about the benefits involved, but I think we should still talk about the potential harms involved with POCUS. The main concerns with POCUS itself, as alluded by the American Heart Association, is that it takes times off the chest and can delay compression skin. So as everyone knows, 10 seconds is generally the amount of times we want for the pulse check for time off the chest compressions. And studies have looked into this in regards to how much time is off when using POCUS pauses. And Kladenberg and Huis and Veld identified that POCUS did cause delay time with 17 seconds versus 11 seconds without, and 21 seconds versus 13 seconds without. As a result, there was a look into future studies that attempted to identify if there was methods, protocols that can help reduce the amount of time off the chest. This led to certain protocols, for example, such as the CASA protocol, the record and review technique, that help to identify, help to improve the time off the chest to make it 10 seconds or less. The CASA protocol is just an example of one of these protocols. So what this CASA protocol involves is that essentially what you want to do is have the transducer on the chest during the compression so that we have time off there. And then during the pause itself, when we are attempting to identify, you want to record the image so that we're not spending time interpreting as well, and have someone count down from 10 seconds as well so that compressions recur again despite the image quality generated. And the sonographer should not be the code leader itself. And this may be difficult in rural settings at the end of the day, so you may have to adjust this based off your situation. Again, this is the CASA exam, another example of one of these protocols to help reduce the amount of time off the chest. So, and then finally, we're going to talk about our last point here, TEE and POCUS guide CPR. So we're going to go to another case here. A 58-year-old woman, BMI of 42, with congestive heart failure, collapses in the ED. They place her on the monitor. There's a PEA complex noted while a pulse. Standard CPR was given. 2 rounds of epi was given. No ROSC was achieved still. And end-tidal CO2 was low at 12 mmHg. A second provider arrives and places a TEE probe during the ongoing compressions. And the patient has been intubated at this point. So in regards to the problem with standard CPR positioning, studies have found that over 50% of patients receiving CPR have standard hand placement of the lower third of the sternum base as recommended by ACLS, suggests that they compress the LVOT rather than actually compressing the ventricles, which is the target, because essentially we want to improve the cardiac outputs with this and perfuse the body with CPR. So multiple studies looking into animal studies as well have identified that those with echo-guided compression positioning helps improves the hemodynamics involved and the cardio outputs involved, and that the standard lower third of the sternum position is not ideal for patients based on variation of cardiac anatomy, body habitus, and pathophysiology. So essentially it's saying that we need to individualize the compressions involved. I believe this is a role where TEE can play in, as TEE itself, compared to TTE, can help identify views of the hearts during the resuscitation itself, where the mid-esophageal, help identify whether or not compressions are actively occurring at the ventricle level as opposed to the LVO outflow level. This is an example of this compressioning happening in real time with TEE. Notice how the ventricles themselves are being compressed during this time rather than the LVOT. So this kind of leads us to the concept of bespoke CPR that Dr. Jellick coined, essentially. So this TEE can be helped to identify that we're compressing the ventricles essentially during the cardiac arrest. It can help identify if there's reversible pathophysiology is noted, or if there is a mechanical organized contractions that is occurring without pulse, which is suggestive of Pseudo-PEA. So this helps really individualize the CPR based off the individual patient rather than any standardized format. Again, there's a large body of evidence with TEE itself that have been looked at in the past couple of years, and I think the key takeaway is that TEE converts POCUS from an intervened diagnostic tool into a continuous resuscitation guide, which is a conceptual leap that helps justify the use of such technology. So going back to case 3 again, they noticed that the hand position was on the LVOT rather than the ventricle. Hands was repositioned to 2 centimeters cephalad with the TEE guidance. Compressions were improved, and as a result, end-tidal CO2 also improves from 12 to 28. Weak organized contractions were also seen, suggestive of a pseudo-PEA, and arterial line shows the diastolic blood pressure of 34. Again, also help confirming Pseudo-PEA. CPR stopped, management was changed to vasopressor, and ROSC was achieved. So again, POCUS plays a role in changing the management in this case as well. In terms of our local practice here, 12 emergency physicians are TEE trained at St. Boniface, with use from September 2024 and February 2025 being the 3rd highest TEE usage in North American emergency departments and the 1st in Canada, based off information that Dr. Jellick had provided to me, suggesting that we are quite the leaders in regards to the use of this technology within the country. In terms of current barriers and paths going forward, TEE itself requires extra training of the POCUS certification. Inexpensive probe to use, and cleaning it does cause emergency departments have it. And it requires the intubated patient itself and needs someone that's not running the code to do it. However, I believe the advantages are unparalleled, as it allows to do rapid pulse checks, guide hand position, and assess etiologies, all while stopping compressions during the cardiac arrest. So in terms of key takeaways here, POCUS can help identify if there are reversible causes involved, such as occult ventricular fibrillation, which changes management. POCUS can also identify if standstill is present and whether or not Pseudo-PEA versus PEA is present as well. And POCUS is ultimately faster for pulse checks compared to manual, with the preference being B mode over Doppler mode. And then in terms of harms, POCUS can cause harm in regards to reducing time off the chest over 10 seconds recommended guidelines. However, with new protocols in place, this can help be reduced. And then the concept of bespoke CPR, where TE itself can help individualize the CPR involved with POCUS. These are my references, and that's my presentation. Any questions?
Thanks, Richard. Great talk. Yeah, we do have 5 minutes or so for questions if anybody wants to chime in or leave a question in the chat. All right, well, if there's no burning questions, I'll just thank both of our speakers again for 2 wonderful talks. And just to highlight, I've left a link to the evaluation in the chat. The presenters really appreciate getting feedback on their talks, so if you can take a moment to fill in the survey, that'd be great. Have a nice day, everyone.